All right, we're going to go through the male genital urinary system in two parts. This is part one. The genital structures of the male organs are the external structure, which is the penis and the scrotum. The internal structures are the testes, epididymis, vas deferens. You can see these in the picture here. And then the glandular structures are the seminal vesicles, bulbourethral glands, and the prostate. When we look specifically at the penis, the specific anatomy that we have here are the three cylindrical columns of the erectile tissue, you can see in the picture, two corpora cavernosa on the dorsal side, which is a sponge-like erectile tissue, and one corpus spongiosum on the ventral side. This lies between the two cavernosum. We have the glands at the distal end of the shaft of the corpus spongiosum, which expands into the cone of erectile tissue. The corona is where the glands joins the shaft. The urethra runs through the corpus spongiosum, and the meatus forms a slit at the tip of the glands. The foreskin forms a flap over the glands. It's often removed by circumcision. And the frenulum is a fold of foreskin extending ventrally from the urethral meatus. The scrotum is a loose sac. It's a continuation of the abdominal wall. After adolescence, the skin is deeply pigmented with large sebaceous follicles. The scrotal wall is a thin skin. It lies in folds, which are called rugae, with underlying cremaster muscle. The cremaster muscle controls the size of the scrotum. It responds to ambient temperature. Inside the scrotum is a septum, and it separates into two halves. Each is called a testi. The testes are solid, oval-shaped, and suspended vertically. The left testes have larger spermatic cord, and it hangs lower. The tunica vaginalis is a double-layered membrane which covers each of the testes and separates it from the wall of the scrotum. The layers are lubricated by fluid so the testes can slide easily within the scrotum, and it helps prevent injury. The spermatic cord ascends along the posterior border of the testes through the inguinal canal into the abdomen. Here the vas deferens continues back and down behind the bladder, where it joins to a duct of seminal vesicle and forms the ejaculatory duct. This duct empties into the urethra. With the epididymis, it curves over the top and posterior surface of the testes. It's markedly coiled duct system, and it's a main storage site for sperm. The sperm is transported along a series of ducts, and it empties into the ejaculatory duct and ultimately into the urethra. The inguinal structures are shown here in the picture. The inguinal area is the junction of the lower abdomen and thigh. It borders anterior and superior iliac spine and symphysis pubis, where the inguinal ligament lies. This is a common site of bowel herniation. The inguinal canal lies superior to the ligament, passing obliquely between layers of abdominal muscle. 4 to 6 centimeters long in the adult. The internal ring is about 1 to 2 centimeters above the midpoint of the inguinal ligament, and the external ring is above and lateral to the pubis. The femoral canal is a space that's 3 centimeters medial to and parallel with the femoral artery. The femoral artery is actually used as a landmark to find this space. The lymphatics of the penis and scrotal surface drain into the inguinal lymph nodes, and these lymphatics of the testes drain into the abdomen. The abdominal lymph nodes are not accessible to clinical examination. When addressing our special populations with our infants and children, we have prenatally the testes developing in the abdominal cavity near the kidneys. In later months of gestation, these testes migrate and descend along the inguinal canal to the scrotum. When the baby's born, the testes measure 1.5 to 2 centimeters long and 1 centimeter wide. And in pre-puberty, there's little growth. Once we hit adolescence, the puberty stage, it occurs earlier in boys than it does in girls, and on average starts at about 9 years in our Black patient population and 10 years for our Caucasians and Hispanics. There's no definite end to fertility like there are in our female patients. We measure sexual maturity on the Tanner stages of sexual development, when we the scale that we looked at when we were doing our female GU unit. And this assesses with the males the scrotum, pubic hair, and penis. There are 2 separate ratings, the pubic hair and the genitalia. If the penis and testes differ in ratings, then they get averaged. The first change to occur is testicular enlargement at about 9.5 to 13.5 years of age. And here's the chart for the Tanner stages for our males. We have stage 1 through stage 5. I'm not going to read them all off specifically, but you can see here the different stages of the growth. In our elderly patient population, the testosterone starts to decline, and it can decline as early as about 30 years. At approximately 40 years, sperm production starts to decrease. We have a decrease in pubic hair. The pubic hair can become grayed. The rugae decrease and the scrotum becomes pendulous. The testes decrease in size. They're less firm to palpation. We have decreased sperm production, decreased ejaculatory force and volume, and decrease in orgasmic intensity. We have a slower sexual response. And the chronologic age doesn't mean a halt in sexual activity, so it does not have to interfere with libido or sexual pleasure. The older male is capable of sexual function as long as they're in reasonably good health. A male may misinterpret normal age changes as sexual failure and become demoralized, so it's very important when we are talking with our patients and collecting history that we respect this issue. With cultural considerations, we can address circumcision here. It can be a religious and cultural practice. It can also be for health reasons. The potential benefits are prevention of phimosis and paraphimosis, which we'll talk about shortly. We have a decreased incidence of penile cancer in our circumcised patients. There's a lower risk of certain STIs, a lower risk of acquiring HPV, a potential reduction in HIV acquisition, and a slightly decreased risk of urinary tract infections. But the decision ultimately belongs to the parents. There are men later in life that do choose to get circumcised, but it's generally something that is done shortly after birth. So our questions for our history of present illness as our patient presents, we're going to ask them if they've got any urinary symptoms. We're going to ask them about their sexual activity and contraceptive choices or uses, any structural dysfunctions, pain with lifting objects. We're concerned about possible hernias. If they've had edemas in their penis or scrotum. If they have any lumps, bumps, lesions, or sores on their penis or scrotum. Feelings of achiness or heaviness in their genitals. Any discharge from the penis. And what their regular self-care is. And if they're doing any type of self-exams on their testicles. And if they're getting regular exams from their physician. Addressing the urinary questions, we're going to ask them if they have any pain with urination, any urgency, how frequent they pee, how much volume of urine comes out when they do. The sensation of incomplete emptying might be occurring. If they have any hematuria or pyuria, that's blood or pus in the urine. Any issues with incontinence. If they have flank or suprapubic pain. if they have any fevers or chills, any nausea or vomiting. And then a decrease in appetite can also indicate that there's a possible problem or infection going on. Here I have a chart with some potential causes for urinary symptoms in our male population. With dysuria, it could be a urinary tract infection, acute cystitis, which is inflammation of the bladder, prostatitis, which is inflammation of the prostate. If they complain of urgency, they may also have a UTI. They may have overflow incontinence from BPH, it's an enlarged prostate. The detrusor muscle may be unstable. If they have frequency, it can be from urinary tract infections. It can be related to diabetes, diuretic use, again, BPH, and just incomplete emptying of their bladder. With hematuria or pyuria, we're going to ask if there's any symptoms occurring with these, with either the bleeding or the pus noticed in the urine. How long has this been going on? How much blood? Is it blood tinged, or is it completely bright, frank red blood? It could also even possibly have clots in it. For pyuria, is it slightly hazy, or is it milky looking? Is there any associated pain? With hematuria, we're going to consider the passage of a stone, a renal stone, a kidney stone, as it may have sloughed off in the urinary tract, causing blood to be in the urine. We're going to consider upper or lower tract tumor or polyps, systemic coagulopathy, or excessive anticoagulant use. So it's important to ask them if they are on an anticoagulant. Less common causes of hematuria are acute necrosis or renal cancer. With pyuria, we're going to consider a urinary tract infection or pyelonephritis, which is an infection in the kidney. And we're going to consider possible renal disease. If the patient does have a catheter, we're going to definitely find out when it was last changed and who changed it, just to make sure we don't have any issues with catheter-associated urinary tract infection. So the different types of causes with hematuria, initially, if the urine flows, and it starts out with blood, but then ends up clear, the problem's probably in the initial portion of the penis or the urethra. If they have terminal hematuria, where the urine starts out clear and ends up bloody, the problem is in the prostate or bladder. When they have total hematuria, just bloody urine flowing throughout the urination, the disease is above the prostate, or they have a massive hemorrhage at any level. With incontinence, our overflow incontinence usually happens with our patients that have benign prostatic hypertrophy. They end up with a large amount of residual urine in their bladder, and this constant increased pressure in the bladder can cause this overflow. A slight increase in intra-abdominal pressure raises this intravesicular pressure sufficiently to overcome bladder neck resistance, and then urine will escape. The leakage may be steady or it can be intermittent. Stress incontinence, on the other hand, occurs with straining. It's a primary defect due to loss of muscular support in the urethrovesicular region. Residual urine is insignificant. Any increase in intra-abdominal pressure causes this leakage, much like with women, as we had discussed in that PowerPoint. There is an acronym, DIPERS, for causes of urinary incontinence, which could be delirium, dementia, depression, infection, atrophic vaginitis in women or urethritis in men, pharmaceutical use, endocrine, excess urine production, restricted mobility, retention of urine, and stool impaction. Sexual questions we're going to ask our patients are if they are sexually active, what type of sexual intercourse that they're participating in, when was the last time they had unprotected sex, if they have a recent history of STI, are they using condoms, are they using any other type of contraception. We're going to consider HIV risk by asking about IV drug use or prostitute encounters, as this increases their risk. How often have they been checked for STIs? Are they having any issues with erectile function? Is it being treated? If so, what are they doing? Then we'll move on to their general medical history. If they had a history of STIs, as we had mentioned, when was the infection? How was it treated? Any current or history of your UTIs? When was it? How was it treated? Do they have diabetes? Have their blood sugar been controlled? History of current issues with their prostate? History or current issues with neurovascular problems? If they have any past surgical history, were any of these GU surgeries, hernia surgeries, when were they performed? Were there any complications? Lower abdominal surgeries, what type? When was it performed? Were there any complications? And then we're going to address their family history. If they've got a history of prostate cancer, hernias, infertility, and if they know what the cause was. We're going to ask them some questions about their health maintenance. Do they perform routine testicular self-exams? When was the last prostate exam? Have they ever had their PSA level checked? And if so, when was it last checked and what was it? If age appropriate, we're going to ask them if they've had a colonoscopy and what the results were, what STI prevention strategies they've used, what cancer prevention strategies have they used. Moving on to our pediatric population, we're going to ask if their testes have descended, if they've ever had a hernia or hydrocele, any problems with the penis or scrotum, such as swelling or discoloration. If we have swelling of the scrotum, is it during crying or coughing? Does the child have any trouble urinating? Does the stream look straight? Do they seem to have any pain with urination? Any histories of urinary tract infections? Has toilet training started, and how is it progressing? Any issues with that? And if the child's over 5, are they wetting the bed? How is this impacting their quality of life? With our adolescents, we're going to consider who's in the room, just like we did with our female patients. We're going to gauge how much this patient knows about growth and development, nocturnal emissions, masturbation, sexual activity, and STIs. We're going to talk with the parents and obtain permission to discuss all of these things. We're going to be matter of fact about it and non-reactive, just like we discussed with our female patients. We're going to consider questions such as when did you instead of do you, as it's less threatening. It assumes that everybody's kind of in the same boat. Expect that some children aren't going to respond. They may completely shut down. They're going to be embarrassed, but we're going to let them know that we're always here for any questions that they have. And we will discuss testicular self-exams with the adolescent patients. With our elderly patient population, we're going to ask them if they've had any difficulty urinating, any hesitancy, urgency, frequency, if we have a split stream, if there's any dribbling, feeling of incomplete emptying, any pain with urination. Are they incontinent at night? How much fluids do they drink in the evening, if that's a contributing factor? Any issues with incontinence? Any issues with sexual activity? Are they taking any current medications? And now we're going to move on to part 2.